Hey everybody, thank you so much for joining the live stream. We are super excited to be back with our second episode of Workers' Comp Wednesday. We have a great roundtable, a full table here of some great leaders and just people who are experts in this field, so I'm excited to talk about this. We're all in the same room, so you'll see us looking around and talking to everybody. And I'm just going to go around and do a quick introduction of everybody. Then I want you guys to introduce yourselves a little bit more. We're going to start things off to my left and also right here on the camera here. We got Stephanie Anderson. She's the Vice President of Workers' Comp here at Mary Free Bed. We have Amy Bowen. She works with a workers' comp team. She's a clinical liaison. We got Aubrey Meyer. She's a case management lead. And we've got Nelly Brower. She is the inpatient care manager. So I want to all just hear a little bit from you guys. Describe your role a little bit more and tell me about how long you've worked in rehab and also here at Mary Free Bed. So Stephanie, let's start with you. If you just want to tell us a little bit about yourself and this role.
So I am a physical therapist by background and came into this role specifically leading workers' compensation about a year ago, coming up on a year ago, but have several years with the organization. My role here is kind of leading out on all things workers' comp from, identifying process or workflow that helps support our team to increasing access and our ability to provide care for injured workers.
Awesome. Amy, you want to go next?
Yeah, sure. So I've been here at Mary Free Bed for almost 6 months. My role here is as a clinical liaison as I work as a single point of contact for internal and external stakeholders. So following injured workers throughout our continuum, pre-admission all the way through outpatient, home and community, things like that. Also a physical therapist by background. I've been in the rehab world for about 5 years in different capacities, working with injured workers in different capacities, but have been here for the past 6 months.
That's great, Amy. Aubrey, tell me a little bit about where you work in the floor and what your role is like here at Mary Free Bed.
Yeah, so I am a social worker by background. I'll be here in July. Will be 5 years that I've been with Mary Free Bed. I have other experience in inpatient acute rehab and a residential neuro facility. Here at Mary Free Bed, I work on the third floor, which is primarily like spinal cord injured patients and a lot of like oncology. But we do get some trickles of stroke or multi-trauma, stuff like that.
And where within the hospital, Nelly, are you?
I'm on the 4th floor, which is typically our stroke traumatic brain injury. I've been here about 2 years, worked in healthcare probably, oh goodness, I'm going to age myself, we'll just say 15. That makes me feel better. Yeah, and so typically with stroke traumatic brain injury, obviously I have a fair amount of workers' comp.
So just so much experience at the table, Stephanie, which is great. So Stephanie, to start this, let's just kind of set the stage. Like, why bring care managers in for one of our early first episodes to just kind of talk about this within the world of workers' comp?
Yes, Stephanie, talk us up, please.
Yeah. Yes. It really was intentional as, we kind of thought about starting a live stream and like what would the first few be. Care management was definitely one of the top things that came to mind. And then even, finalizing everything. Again, care management being probably the top priority, obviously, the second one. And the reason for that is that our care managers really are a significant part of our communication and collaboration with the members of the claims team. So we talked about that last time a fair bit, what it looks like to communicate, collaborate, do that efficiently, do that effectively, and then support the transition to next level of care. But certainly, and we mentioned this last time too, on the national transitions of care, it really is for inpatient, these ladies that are leading out on the communication and painting the picture for the individuals that we're working with. So it's really important to me that we showcase their knowledge and the way they contribute to our team.
So, and we have lots of people that are watching this from all different areas of the world of workers' comp and healthcare. But so we're all kind of on the same page. Aubrey, do you mind how would you define like acute inpatient rehabilitation, and what does the role of like a care manager a social worker, case manager be in this?
Yeah. I mean, I think inpatient acute rehab, it's the most intensive level. You're getting 3 hours of therapy or a little bit more than that 5 days a week. Really, I think our team approach is to just equip the patient that this is the kickstart of your recovery, right? Like, you are going to do as much as you can here with the goal that recovery doesn't end when you leave these doors. And so I think that's what's special about our ability, is to kind of set up the big picture, that, outpatient, home care, whatever the next transition looks like, that we are giving that education on the forefront. I always think that care management is kind of the glue of the interdisciplinary team, right? We have the mindset of we are the most fluid, flexible piece. I think a lot of disciplines have their roles and they're kind of stick to what they know. And I think that's what's so unique about care management, is we have the fluidity to be able to understand all realms of rehab, and beyond, outside of just inpatient. So a lot of collaboration is, with adjusters, external case managers, your therapists, your nursing team, the provider, other rehabs in the community, outpatient. So yeah, and obviously patients and families, that's the whole priority.
Yeah, I think to add to that, like we work a lot with the families on like helping them understand that this is just, like you said, this is just the start of it. Like the end, you're not going to leave here being completely independent. You are going to continue to work, and what that's going to look like is, I think, part of our role too, just to help them understand that you might only be here for a handful of weeks or what have you, but it will continue, and this is, what that's going to look like.
So Nelly, can you maybe share an example of a patient that you've worked with that has had the multiple layers that Aubrey was kind of talking about?
Yeah, I have one right now. He's been with us, I don't even know, 160 some odd days. So he's had a very complex stay, had multiple surgeries, actually having surgery again coming up, and then will need to come back here to do continued treatment. So he has, I think, 3 different specialists, obviously his external case manager, myself, our whole team here, and his family, and the patient himself, trying to explain everything and make sure everybody's on the same page. It's complex, but thankfully, I feel like all the kinks have pretty much been worked out because he's been here for so long. Because sometimes when it's a real quick stay, then there are a lot of factors and a lot of people you need to be constantly communicating with. So I think we've come into a good rhythm with this group. So everybody's on the same page. I'm frequently talking with the external case manager, and she knows she can always reach out to me. Same with family. So yeah, it's been a very busy case, but he's quite enjoyable, so it makes it easier too. He's a fun guy.
I think you make a good point too, where I know in the last episode we talked about like the collaboration and being able to, work together with external stakeholders and the claims team. But some of these situations, you're also dealing with other hospital organizations, right? So those specialists may be coming in to your acute inpatient to help supplement, or the injured worker is actually leaving for appointments, and you're trying to gather all of the medical history and figure out new orders or new labs that need to be ordered or anything like that. And so I think that's something that, to highlight that it does take kind of a village to be able to keep things organized, and between, the people sitting at the table here and also the external case managers or adjusters, being able to work together with the injured worker to figure out next steps and when are we scheduling these surgeries, procedures, et cetera, to make sure that all areas of the patient are really taken care of.
So looking at that patient, and maybe if we needed to look at another one, we could too, but examples of things that worked really well over those 160 days, or maybe things that didn't quite work so well at the beginning?
I think transparency has been a huge player in this. So the external is very, very involved. She goes to a lot of his appointments, so she might know something before we know something. And so she's been really great about sharing that information. You know, it took a little bit ironing out some kinks initially when he got here. But I feel like, yeah, the team is all really involved and constantly sharing new updates on what's going on with him. Because ultimately, I mean, he's been here so long, he's part of our team now. You know, we really care about him and want the best for him. So I think now that, you know, I can't think of anything besides the kinks have been ironed out, I think everybody's it's just running really smooth.
I can dovetail into that.
Yeah.
I have a work comp right now too. And I think what's super helpful is I think having like a tag team approach sometimes. Like my patient has been having a lot of procedures while he's been here. It's extended stay. And so I think, yeah, this external case manager, same situation. She's attending a lot of the appointments, so she has information. She's plugging that back into us so that we are abiding by orders or recommendations or doing things that we need to watch a little bit more closely, such as wounds or things like that. And I think it's been great because we have this information. We know what to keep an eye on and look out for, and then we can give her that information and feedback. So when she has another appointment, she knows the questions to ask, maybe troubles that we've been having or concerns. So I think the communication has been great, I think, and having someone that's a boots on the ground that can go to those appointments is helpful.
Can I ask a question
Yeah.
maybe as a response to that? Because you talk about communication, and as you were both talking, I was thinking about like, maybe even that we referenced in the first episode, that can be really challenging in light of the fact that our care teams are so busy, but then also that adjusters are really busy in managing like huge caseloads, and so are the external case managers. Like, if you could maybe share, you know, the things that we've tried in order to kind of streamline communication, maybe touch on like things we tried that didn't work well or things that we've put in place that have been received well, both for like short stays or for longer ones, but knowing that case managers are all very different in what they need or how they work. So kind of reconciling that, you know, our team works with a lot of different types of case managers. Could you speak to that? Maybe if you start, Aubrey, and then Nelly, I'd be curious too.
I think now we have more of a streamlined process for that. I mean, since Amy and Stephanie have been, you know, targeting this population a little bit more, they've developed an email system which has worked nicely. I think all of us in the beginning have done, as far as care management, have done a good job at like reaching out to adjusters and external case managers, but not always asking maybe the question of what is the most efficient way to communicate or keep you updated. So I think now having a consistent email chain, this thread going where we're tying in a template, you know, stating who's responsible for what task, you know, what's your expectation. I think laying that all out on the line in the beginning has really been helpful and beneficial for ensuring that all of us are on the same page. We know who's doing what task, and we can always use that as a point of reference to go back. I think that's probably been the most efficient thing that's happened.
That's been a game changer.
Yeah.
I think reaching out to them pretty quickly after they get here and just saying, hey, this is who I am, this is what I do, please email. I prefer that. Because like you said, we are out of our office a lot during conferences and talking to families, so email tends to be easier, and then it's all documented as well, just because if you can't follow up on something immediately, you at least it's written down so you don't have to rely on your memory to be able to respond back to them. But yeah, that has significantly helped, I think. And I also want to, our DME coordinator, I think Lindsay Stevens and Monique have been like incredible with our workers' comp, because I know how challenging it's been because they have their own preferred providers. We, of course, want to use CareLink, but they have their own preferred providers, and I know they've worked so hard on making sure patients have the DME they need when they go home. They're so quick to jump in.
I think that template and like that upfront communication has been super helpful to just know like what are the expectations for this particular case, right? Like, are we attending in-person weekly team conferences? Are we on the phone? How often do we want updates? Because I know just speaking from knowing all of the inpatient injured workers, you know, that situation looks different from every single one. But being able to know how involved the external stakeholders are going to be, and then what that looks like for our team to be able to appropriately get in touch, you know, with whoever is important to get in touch with, and in the way that's meaningful to them, right? Like you said, if you guys are not in your office very often, calling is going to be challenging, and so maybe email is more preferred and those sorts of things. So I think being able to identify those expectations very early has been helpful for your team as well.
I'm curious too, you said, Aubrey, that you had one too, and you guys have so many patients that you see at the same time. Do you ever see maybe like two workers' comp cases at the same time? Okay.
Yes, I do. Yeah, I've had, I think, 3 or 4 at a time in workers' comp and some auto, but the intensity is similar on each. But yeah, I've had a handful at a time.
And then how does the team like Amy and Stephanie help with that? Because I mean, it's all about collaboration and
Right.
communication.
Yeah, that's been really nice having Amy helping with communication. 'Cause thankfully, I'm trying to remember back when I had all of those. It was similar external case manager, so that's been kind of nice. Yeah, just everybody steps up and helps, though. That's what's been nice in our department. You know, my coworkers in care management help pick up the slack with maybe some other ones or step in for other things. So
I think too, you know, we as care management, we have a lot of people on our caseload. And so I think sometimes like things can fall to the wayside. Like it happens. We're human. And I think that's been really nice too, to have Amy and Stephanie, you know, just be kind of a go-to person. So if a case manager needs something and if we don't have time, Amy can kind of step in and help. Or, you know, if something, you know, maybe we missed sending something or updated records or what have you, it's nice to have that, hey, reminder, send these things. So I think that's always helpful too.
You touched on something, Nelly, that I think is always interesting is as you build a program that encourages more injured workers within your rehab world, inherently you are also going to get to know the external stakeholders very, very well, which can be super nice, right? Like you can have 2, 3, 4 work comp cases on your individual caseload, but I do see that as a perk of maybe you have the same external case manager for 1 to 2 of those cases, which then it makes things a little bit easier because you build a relationship, build rapport personally, so that way the next time one admits, you know, you have that strong foundation of relationship already built too, which I think is encouraging.
And I think the expectation. You
Yeah,
kind of
yeah,
know
yeah.
what their expectations are of you and, yeah, the flow of
Yep.
which they work.
Yeah, definitely.
We talked a little bit about processes. Are there any like tools that you guys use that help you in this?
I don't know of specific tools. I pride myself on being extremely organized. I don't know if I didn't write things down how I would function, because I'm of a certain age and I have children and my mind is always running all over the place. So if I don't write it down, I always joke with patients, if I don't write it down, it's like it never happened. But I think just staying on top of things, writing it down, keeping organized, documenting right away, that helps me.
Tools, I mean, yeah, I think just as I said before, the email with, you know, the template and things like that, that's been helpful. I utilize my Outlook calendar like nobody's business because I always like having reminders of to do things. But yeah, I think this is kind of similar, but not really a tool. But I think even just like the connections you form with these patients, because they do take so much time, the patients and their families and the external, you're working with so many people that it's hard not to get to know them really well and know how they operate and what, you know, what's helpful to them. How are they going to take specific news? You know, so I think learning that side of people is almost a tool in itself because you're getting to know them a lot better than you would some of your other patients that don't necessarily stay with us as long. So I think just having that rapport is a great tool.
I will add, before the patient or specifically the injured worker comes to us, our utilization teams, the people who are communicating with the payer ahead of time, are also using templates. And we have kind of built, again, over the course of really intentionally focusing on this industry and patient population, specific questions that are helpful to set care management and the clinical teams up for success too. So very early on, those representatives are asking about networks, right? So they ask is there a network involved on this claim at this time? And that helps to start, providing that information to the DME coordinator or to the care managers, so that we already kind of have a sense of preferred vendors, or we're already walking into the relationship with the external case manager with some information in hand. So some tools kind of across that continuum. And I think we even referenced standardizing where we keep contact information for members of the claims team so that the whole team knows exactly where to look in order to reach the person they need to reach. So some of those tools at this point, I think, maybe even don't feel like tools anymore because they've integrated into the workflow to make it more effective and efficient. So,
Amy, anything you want to add to that too?
Yeah, I mean, I would echo what Stephanie said. I do think when we have rolled out these templates that Aubrey and Nelly are mentioning, these were rolled out very kind of quickly. It came to fruition of hey, this is something that would be helpful. And so the care managers have kind of taken it and run with it. And I do think that there's certainly some benefit to that. But I do think there's something to be said. And I know this was mentioned in our first episode of, creating pathways for ease. So not trying to change processes entirely for the work comp population, because it is just going to be a small population of the entire rehab hospital, but how can you leverage different tools, AI, email chats, templates, things like that, to be able to make life easier for those clinicians that are doing the work. So I think that's something just as a tip to kind of take away, is looking at what you're doing now for all of your patients, and then how could you leverage some of those ideas, tools, and brainstorm some things to be able to make it work for injured workers too.
It's just so interesting to hear this all, because it really leads into the next question, where we're working with so many different parties and each group has their own priorities. But how do you work on juggling that when you've got the employers, the adjusters, the medical teams, but you're trying to make sure you focus on the worker, the patient? How would you, try to juggle those priorities?
That's a good question.
I think you have a great case right now that involves a lot of juggling. And I say that from a sense of there has been a lot of juggling from the get-go medically, and also dealing with home modifications and things along those lines. And I guess when Chris asked that question, that's the first person that came to mind, was that case, because I think there's just so many different layers and different priorities that have changed over the course of 6 weeks. I feel like every team conference we get into that, and it's oop, this is something new, different, or something we need to focus on now. So yeah, I don't know. That was my first thought, is thinking of that particular case.
Honestly, the only word that's coming to my mind is fluidity, right? I think you have priorities in the beginning, but I think you have to be open that these are going to shift. The intention is rehab, right? And I feel like when people think rehab, you're thinking, I want to get up, I want to walk, I want to get stronger. But sometimes it's you're in that space and you've kind of not capped out, but that may not be a big priority. This gentleman that you're talking about, yes, he's made some really great functional gains, but also now we're kind of teetering more on the side of medical complexity. So a lot of these things have been kind of pivoted to focus on the medical side of things, and then also pivoting to home modifications. So I think priority is just, it's fluid, and you have to be able to roll with the punches in these cases.
Yeah. When I hear you talk, though, I think that brings me back to your introduction of being care management being the glue, and being sort of the person that stays, or or kind of oscillates to the perspective of the big picture. Whereas I know we've talked about this and you've been like, the therapist is really focused on like their RTI output, and that's exactly what they should be focusing on, is like really specific measurable gains. But for your team to be the person that, in collaboration with the external case manager out of a discipline, is zooming out, seeing the big picture, and then from that perspective, identifying where those values might land. And you're the ones that are interacting with people from the claims team who bring, potentially their priorities, or even boundaries on what's going to be possible within covered services or whatever. So you're the one that is then articulating that or bringing that back to our team, which I just think is, again, maybe brings us back to like why I think this audience or your participation is so important in this, and stimulating conversation to whoever's listening, that these are interesting things to consider. So
yeah, and it's probably ways that each facility, you come from different backgrounds, different places that you worked, and they might all approach workers' comp in different ways. So I just think Mary Free Bed, we always put our patients first, and this is just another way of doing that. So, and then you mentioned it too about the different types of patients that you work with. Maybe share like what those differences are like when you have a huge caseload of people you're working with, but you have a couple workers' comp and then you have some non-workers' comp. Are there any like differences in the way you might not necessarily treat the patient, but treat the way they handle the case and working with the patient?
It's a good question. I think for me, I try to like meet the patient where they're at, because I always try to remember, like when I worked with patients who had dementia too, like, or any situation, like this is probably one of the worst times of their life this patient's going through. So bringing some joy and some levity and, humor sometimes, like my one gentleman, he's very funny, and we call him Trouble. Like he just is so joyful, like just trying to just have some balance too, because we're all going through something. It's just a matter of whether you can see physically what someone is going through or not. So, do you have anything to add?
Yeah, I mean, I'm thinking more along the lines of how are these cases separate, right? A lot of times when you have payer sources that have more resources, you're thinking about the long term. Okay, when you leave here, what are you going to need? What do you get access to? I know that language is strong. What do you get access to? But really, that's kind of the truth. I mean, when you have commercial insurances or state insurances, it's almost as if, we have parameters on the resources that we are, being able to access. And so I think when you're dealing with like the autos or the workman's comp, there's a little bit more leeway there. And so, yes, we're dealing with our interdisciplinary team, and the adjuster, the external case manager, but a lot of times if some of these people are going home and they need caregivers, that are paid through that funder, we're working to get that secured. So there is a lot of juggling in that way.
There takes a lot of creativity, I think, too. Yeah. Like regardless of payer source, we have to, part of the joy of social work is like coming up with, being resourceful, but also coming up with different options for loved ones, because we are caring for people whose children are still working. And so it's hard to care for your loved one, your parent or whomever, when you still have to work full time. So it's been a challenge, but enjoyable sometimes, but a challenge.
I think one of the things that can be helpful, and you can agree or disagree, is in being able to have access to additional resources, not only things, right, organizations or things, but you also have the nice perk of having access to an additional person who's also on your team to help leverage some of this. And I think of some
Do
of
you
our
want more of our work?
No. happy to be that person. I was mentioning but you also have an external stakeholder who can help find those resources too. And I think about a lot of our injured workers who come from rural areas, or maybe they've never been in a healthcare system before, never had a primary care doc, whatever. And you have an additional person to say, hey, do you have any resources in this area, in this state, wherever it might be? Because sometimes it gets sticky, right? Like, it's like, hey, we live in the middle of nowhere and I'm not sure who's going to get out there. But I do think, one benefit is being able to not only have access to additional resources, but also having a legitimate person to be able to
Or just
leverage.
brainstorm with.
Yeah, yeah.
I think is nice.
Yeah, I had a injured worker who lived in the middle of nowhere. I have to look up on a map where most everyone in Michigan lives, but I had to look up where he lived because I had never heard of it. And it was in the middle of nowhere, and so getting him to outpatient was impossible. So family, through their workers' comp, who worked her tail off to help, she got them a van so the wife could transport to come to Mary Free Bed to do outpatient therapy, and they lived hours away. But it was really important to her because she wanted to come here to do therapy because we took care of her husband, and she, felt like we were the best. So that's what she wanted to do. And her external helped get her a van. So she made it happen. I know, it was pretty great.
Amy and Stephanie, is there anything else you want to ask more about this specific question? Maybe when it comes into like functional updates or clinical discussions, or just like expectations from the external partners that they're working with?
Maybe you guys could talk, I'm thinking about like functional updates and whatever. I think maybe highlighting how in inpatient rehab, that weekly team conference, like what that looks like, and, how we've explored further engaging the external case manager as like a really active participant in the team. Maybe speak to that, because I think on the inpatient side, that is where we're giving a lot of the like summary updates, where those might land somewhere different with an outpatient patient or someone coming to the pain program. Those might look differently, but could you maybe share both like what happens during team conference, but then like what updates you send as far as like from the record, like what you're sending to them after the conference?
Sure. So part of when we first initially talked to the external case manager, we're asking their mode of communication preference, but also like we do weekly conferences, this physician is this specific day. Is this something you would like to attend in person, or is this something you would like us to conference you in on? I have the same external for 2 patients. Well, I guess 1 discharged this week, but 1 patient presently, and she prefers to be called every week. So every week I call her. I always email her the day before and let her know what time it's going to be. She almost always answers, and so she can ask. So the team goes through their updates, the physician, the nurse, myself, PT, OT, speech, and then she has time to ask some questions. So she feels part of the team as well. But yeah, this patient we have has been with us so long now that I think there's so much trust that she has with the team that we're on top of everything. And then I always email her weekly updates after conference just to make sure she didn't miss anything, and she knows she can always email if she has more questions.
Yeah. No, I agree with that. I think too, during team conference, I think it's especially important to just offer space for that external person to be able to ask questions, clarify things, or, like I said, my guy who's very medically complex right now, she's attending a lot of those appointments, giving updates, kind of talking through that, what we should be keeping an eye on, things like that. So I think that's been really helpful to just offer that time and know that these are external stakeholders that we want to continue to work with and that we want to keep them engaged in our program. And so just offering that time and respecting their time to do that.
I would just add to that too, like not only them asking the questions, but then bringing, right? You guys care for the most complex workplace injuries, and yet some of them are a little less complex. Like we will get a multi-trauma that is a shorter stay or something like that. So that space allowing for them to also be able to help our team understand, hey, maybe this one, the carrier, the employer, whoever is going to want this to be a pretty short stay, allows for our team to then adapt to like, okay, well, what do we need to do within these 7 days? Because it's unlikely that we will be given an extension based on medical necessity or whatever. I mean, you really do run the full spectrum of what you might be moving someone through pretty quickly, or you might be having people from the claims side of it say, we want them with you longer. Like that really, we span the gambit of that. So I think, yeah, you just saying we create space for them to bring their insights to is really helpful for our team. Yeah.
The other thing I was going to say too is those short stays that you're talking about. We've had times where patients will come to us and the external case manager is like, I was just assigned before they left acute. So yeah, they're trying to understand this person just as much as I am. And thankfully, like I get access to that person every day because they're here with us. And so I think that's kind of something to be mindful of, is that, you know, we want to make sure that they know this patient, that they're aware of all the deficits or things that we need to work on or barriers to get them home or whatever that next step is.
I think I keep going back to that fluidity word because speaking for like short-term and long-term stays, even those weekly team conferences look a lot different too. Especially, you know, we have some external case managers, adjusters that we're used to working with. We know them very well. But sometimes, you know, it might be a telephonic nurse case manager who's in another state or city, and sometimes those can be those shorter stays. And I think then those conversations in team conference change a little bit, right? Because it's leveraging the both of you of what resources do you know of, and how can you be a resource to me to help make sure this injured worker gets what they want. But I think those conversations just they can look different based on whatever stage that patient is in. The nice part about, you know, when we get to the longer stays or those more catastrophic cases is they really just become a member of the weekly team conference. You know, at the very end, it goes to, okay, external case manager, like what updates do you have? And it really is like part of the team. And although we allow that space for the shorter stays, we just unfortunately don't have the amount of time to build that, relationship and rapport with them. But I think that is, nice to kind of highlight though too, is that they really are a part of the clinical care team. And
well, I've had some physicians in some of my conferences like, hey, let's wait for Nelly to call external before we get started to the resident in the conference or something like that. And I was like, that's right. That's right. Thanks for the reminder.
Wow.
That's right.
In all of this is building to getting the worker back to work, but also getting them back home. What's it like for you guys trying to help make that smooth transition from acute rehabilitation to then getting home? Aubrey, anything?
Yeah, I mean, communication, right? I think that's always kind of the start of it, is making sure that everyone knows what discharge date are we working towards, what things do we need to have in place, whether that's ongoing therapy, attendant care, making sure that we're training, if they're hiring staff or if we have to have family come in, if they want to be paid caregivers, we're training appropriately, making sure equipment delivery is occurring, and that things are covered, and going through all the logistics of billing. So there's a lot that goes into it, and it's not all roses, things fall to the wayside. But I think having good communication, especially with the family members who are at home, if they're receiving the equipment when it's delivered, if there's issues, they call us. So it's a lot of room for planning and troubleshooting in alignment with that date. And I think the other piece too is, we always have that discharge date established, but I think knowing that there's room to flux that if need be, because we want to ensure that when we're discharging someone back home, it's so important that the goal is to return to work, that we're making sure that this discharge is going to go smoothly, so that next step is just more preparation for return to work.
Sorry, Aubrey was saying about communication. Nelly, like anything specifically you try to do to communicate or collaborate with external partners during this phase to home?
I think we're always in conversation with them. It seems like that. I wanted to add to not to get off topic of that, but we often, it's the social work care managers that kind of lead the charge, I guess, for lack of a better word. But then we also have our nurse care managers who, if they're a medically complex case, they also then get involved towards, nearing the end of a patient's stay here. So we're looping them in to help organize oxygen or tube feed supplies or wound care, dialysis. Like, there's so many more factors that have to get, mixed in, figured out. Yeah. It's a lot. It's a lot of juggling.
I am going to ask, the complicated question because I just want to talk about things that are difficult. But like, can you just speak to like the challenge that it can be when there is like a preferred vendor or a network, and then you're kind of, that adds the layer, like we've already established that every claim is different and there are different layers in every claim. Can you just speak to like how your team kind of manages that, or how that changes communication or doesn't change communication?
Yeah, I can think of one particular case where we have an idea of, the therapist will place orders with CareLink and then we can get it quickly delivered, but the workers' comp has their own preferred DME provider. And so because naturally their role is to help manage the costs and things like that. So they don't want to automatically use CareLink. They want to see if they can save costs somewhere to help, so we've run into some incidences several times where the external has reached out to a different DME company and there's, out of state. And so there's some lag time with that. So it's staying on top of things. It's like constantly wanting to check your to-do list, that DME has been coordinated to make sure that the patient can go home with everything that they need. I've had a patient go home before without the right lift for home because of DME barriers. So it's really just being creative and helping solve those problems in the moment.
Well, and I think
again to Lindsay.
Yeah, Lindsay.
Exactly.
Bless
I was
you.
going to say,
Taking the brunt of it.
Yeah,
I know.
I think just that, like, the
Insecurity.
the ramp up in
Oh.
the amount of communication and, like, really clearly setting the expectation, right? So, like, identifying if there is a preferred vendor. And just for clarification for those who might not, identify, like, CareLink, why do they keep saying that? Is that we have a DME provider that's in our hospital. So for a lot of patients that come, with different funding sources, that does make some of the DME coordination for them a little more efficient. And yet we acknowledge that for the funding sources that we're working with through work comp, that CareLink may or may not be in their network, and so we're prepared to be really dynamic about how we can coordinate with their preferred vendors. But yeah, it seems to take a ramped up communication that is really happening, like, maybe many times throughout a day leading right up to that discharge, and knowing our team wants to partner with them on managing that cost. But we also know that sometimes if it delays the discharge by 3 days, that also represents cost. And so our team is very aware of that, and we want to be able to partner closely with them on that. But yeah, it's just the layers, that everyone is a little different. And I know that can be somewhat tricky sometimes.
I've started asking sooner than when I first started doing workers' comp about preferred providers for things like that. And I recently had an auto case who was a very short stay here, maybe a week. And the external, thank goodness, was super on the ball. And he was like, this is what I prefer. I prefer to use Northwoods, but they've already been in touch with Dave and Gary at CareLink, and, we're already on the ball. And this was like my first encounter with this external. And I was like, oh my goodness, this is amazing. Like, it was so organized and seamless stay, knock on wood. Yeah. So, because he's still here. But.
Yeah, and I think the more catastrophic cases, sometimes the more equipment and medical needs too. So it's, getting creative and figuring out what vendors are actually going to work, what can they provide, can they deliver to that area. I know we recently had a case where it's, maybe they can deliver to the area, but what's going to happen a year from now if he needs servicing, and making sure that, that vendor is available. So it definitely takes a village to be able to figure out all of the puzzle pieces and make them all fit together by the end of their stay here.
And I think our equipment coordinators do a fantastic job navigating that. I know they usually make it their first priority, to call these stakeholders and ask, what is your preferred? And then if things do change down the line, offering that option, like, hey, we do have CareLink in-house. Are you guys good with this if something falls through the cracks with their original preferred provider? So I think, like, again, fluidity. We're always trying to kind of piece together the things just to make sure that this discharge is going to be smooth.
Are there other common challenges you guys see? And we've talked a lot about that so far, but what are some of the most common challenges, like within this world of workers' comp in rehabilitation?
I would say probably attendant care is a big one. Obviously, auto is a whole another ballpark right now, but I think with work comp, there is a bit more security in it. I think, again, just kind of talking what you were saying earlier about rural areas, I think if you're having somebody that's needing significant care, and maybe the family can do some of it, but not all of it, it's trying to just nail down what are our options for some of these people. And that in itself may pivot the entire plan. You know, if they can't have access to these attendant care options that are, you know, way up north, then it might be like, do we need to look at an extended stay hotel somewhere, or do we need to look at a residential stay in the interim so that they can heal or they can gain more function and then kind of go home from there?
And I think as you speak to that, you add even additional challenges, right? Because you want something that's going to fit that person. And I know that there's been talks and team conferences and things like that of this would be a great place for this injured worker, but he or she is, you know, on the younger side, more active and those sorts of things. And the facility would be great, but it's maybe not a great fit because the rest of the population of that facility doesn't quite fit that mold, or they're not allowing visitors to, you know, stay and be near. And so I think, yeah, you just kind of hit the nail on the head that you can find resources sometimes, and then for some reason or another, it may not be preferred by the worker, the family, you know, the external, what have you. So it does take a little creativity and knowing people to be able to reach out to.
I've had some cases where I'm like going to Aubrey, like, okay, I'm thinking of everything, right? Like, have I missed something? I just need the validation that, like, yes, I've thought it through. Okay, good.
Nelly, how can a multidisciplinary team maybe address some of these challenges early?
Yeah, I think, you know, knowing the therapists and knowing kind of how each other work has been really helpful. I found the longer I'm here, the more I kind of understand how the therapists work and how they think. I think just, yeah, we love that transparency word, but I think, yeah, usually in the initial care conference, this is what I'm saying, like, this is what the patient's goal is. This is what we want to support them in. Whether or not we really believe it's super realistic is one thing, but, you know, we want to focus on plan A, but also establish a plan B. And so I have a patient right now, he's not workers' comp, but I think it still applies, where the goal is to go home. Do we think it's really realistic? Maybe not, unless they have a lot of support. So I'm just trying to over-educate the family on these are things you can look into if you want to keep your loved one home. And I think it still applies for workers' comp. Like, absolutely, you want to go home. You know, this is your goal. Well, these are the steps we need to get you to that goal. And so working with the IDT to just help provide them with resources. You know, sometimes, like with the patient I was just mentioning, I have family training coming up because the goal is to go home. We are cautious about it, cautiously optimistic. And so we're doing family training because that's a big piece of what we do at Mary Free Bed, because we want to ensure success with discharge. So I have family training set up next week so the family can really feel what it's like to be the caregiver for their loved one the entire day. Because as we want to support the goal to go home. So at the end of the day, that's what our focus is. So I think just helping reorient the therapists also that we might feel as though this is unrealistic, but we also need to remember that this is their goal. So they need to know that they gave it a really good try. And if it's not successful, then at least we've prepared them for alternative options.
Aubrey, as we're getting close to starting to wrap up this conversation, you're a lead, and so you probably work with other care managers. How do you work on like mentoring those care managers, and maybe even any like advice you'd have for someone who their first workers' comp case?
Yeah, I mean, I think communication is always key, and I think that's probably something that I'll never stop saying, even to myself. I think over communicating is always helpful. I don't ever want to be the reason why something fell, or because someone wasn't informed or the patient wasn't aware of a plan or something like that. So I think just trying to educate our team, like always be on your game with communication. I think advocacy too, that dovetails right into what you're saying. You're advocating for the patient. I get it may not always be ideal, right? It may not be what we think is best or what we are necessarily hoping for. But if we're advocating and trying to do our due diligence to make sure that we're exhausting every avenue to meet that patient's goal of getting home or whatever that next step is, and then, if it doesn't pan out, we can say we tried and we did give it our all. So I think, just to our care management team, like communication, flexibility, advocacy, and just we're awesome as far as coordination. Like we coordinate so well, like we really do a great job. And so, I think even just like building up our team, knowing that we have such great people to fall back on, to brainstorm alongside. And I think too, like, a lot of collaboration with external stakeholders, our personalities may not mesh. I think it's always trying to figure out how can I work with someone that maybe I'm not, like our communication styles are different, So I think trying to just realize that and acknowledge it and say, okay, we have to forge on no matter this issue. And again, just falling on your people in your team and your coworkers, knowing like, okay, this is what I'm being asked to do. I'm not quite understanding. Can you help me clarify this? So I think being able to do that, I think at the end of the day, like we figure it out and we get it done and they move on in their recovery.
Like the worst in my mind, like I think when I first started working with the workers' comp population, I think I had to remind myself it's not that bad to ask a question and be like, I'm not really understanding. Help me understand this. It's not a bad thing to ask a clarifying question. That sounds very social worky of me, but c'est la vie. But it's not bad to just say, I'm not sure I really understand what you're saying. Like, can you explain this better?
Mm-hmm. And I think that's like the beauty of Mary Free Bed, right? I think we can always have the opportunity to say, educate me on this. I have no idea, or I've never heard of this. What does that mean? And I think too, like, insurance and all realms of it are always changing. And so I think, again, just being flexible and asking questions to make sure that I'm understanding, because I do want to provide the best care. And I think all of us do here at Mary Free Bed. That's why we're here. And so I think just being able to acknowledge those hard things that we don't always want to makes you a better clinician.
One thing I think you guys have done well, and I don't know if it was always intentional, and it's not like it's labeled on a badge buddy, but I would say within every department there's probably kind of champions that maybe have experienced more in the work comp realm, or what have you. And so I think being able to rely on each other of like what's worked in the past, what hasn't, brainstorm, so that way when you have different care managers stepping into those roles, or different assignment or whatever, you at least have a core group of people to say like, hey, this is what has worked, and like we'll figure it out and get through it and kind of be able to help along the way.
And as we wrap this up, I want to hear from Stephanie and Amy, maybe what are some takeaways from this conversation? We had two awesome and really well-versed care managers who shared such great tips and their experience for our viewers. Amy, I want to start with you. What would be like a takeaway you think that for our viewers from this conversation that you heard?
Yeah. I think as the conversations just continue to like roll, and having Aubrey and Nelly here, which thank you guys, this is great. I just keep like hearing the words of like communication, transparency, fluidity, and those sorts of things. And I really appreciate, Nelly, you just saying like it's okay to ask, like I don't understand, or I don't know exactly what you mean by that, because at one point or another, all of us in this room were unfamiliar with workers' comp, and I'm still not an expert, but I think being able to admit that and being able to just ask those people within the world of work comp to say, educate me, please. Like, what does that mean? But I think not being afraid to ask questions, being able to work together, and then being able to communicate clearly and proactively is probably some of the biggest things that I heard, today.
Awesome. What about you, Stephanie?
Just hearing Amy say that, and Nelly as well. One of our viewers last time made a comment, and it was very short but impactful to me, that she just said, work comp takes work. And I just appreciate that
Yes,
like
girl.
it does take work.
Yes, girl.
Yeah, it does take work. And that, being vulnerable and saying, can you clarify? I don't know what that word means, or I don't know exactly how you're, laying that out. Can you help me? Is how we learn, and it's how, we support our teams. It's how we support, injured workers. It's how we support our referral partners in this space. So I just really appreciate that, like the vulnerability. But then before you kind of took that one, I was thinking, well, obviously it resonated. I was just, the word that sticks in my mind is expectations. So to the best of our ability, aligning expectations early and then often. So being willing to adjust those expectations, but align on them with all the members of the team. So the clinical team, the claim team, whoever, staying aligned on those, I think, is really helpful.
Awesome. Well, Stephanie, end this here with how if someone can find out more information about workers' comp at Mary Free Bed. How can they get in touch with you or any of the team?
I will direct you to workerscomp@maryfreebed.com. That is an inbox that we all have access to and are interacting with every day. And so if you're interested in learning more or have an injured worker that needs care, certainly you're able to email that inbox.
Awesome. Well, it's for Stephanie and Amy and Aubrey and Nelly. Thank you guys all very much for joining us. We'll be back again next month with another episode of Workers' Comp Wednesday. Send in your questions, anything you want to hear us talk about. Thank you for watching, and stay well.